I'd like to present setting up stroke intervention service and the training requirement for cardiologists. In Turkey we have 125 stroke every year, and every 5 minutes someone has a stroke. 1 in 4 men and 1 in 5 women has a stroke. And mortality rate is around 50% after 1 year. So I learned from the studies that stroke intervention decrease mortality and morbidity, decrease length of stay of hospital, decreases cost, and improve patient outcomes. So why I involved in stroke intervention, I'd like to explain a little bit. So who will perform this procedure? So we know that this procedure is extremely useful. I mean, it decreases mortality. So who will do this? In Turkey, we have 10 to 15 neuroradiologists who are able to do this work. But most of them work daytime. And there are 8 interventional neurologists that are quite active. They work 24 hours, but their number is also limited. In Turkey, we have 250,000 PCI every year, and we have more than 300 cath lab, and we have more than 1,000 interventional cardiologists in the country now. So, for example, my hospital needs this treatment since many large vessel stroke are admitted there, and we have also already a stroke unit, and we have a great relationship, very good relationship with neurologists, and they really support to start this procedure. Personally, I have lots of carotid stent. I did more than 800 now, and we do every year between 80 to 100 carotid intervention for some years. And my cath lab also ready for, of course, 24 hours for any acute intervention. Also, we have nurse and technician during the night. So this work seems to me the most rewarding work I could ever do, actually. We have seen Asim's video today. It was very, to me, very exciting. And of course, I could not stop myself to be involved in this work. And also, we should help neurointerventionalists, because we have a paper that's saying neurointerventionalists has burnout problem because of volume load. They work a lot, and they have burnout syndrome. So somebody, I think we had better help them, because they work very hard. They were, if also they work 24 hours because they only could do intervention, stroke intervention. If they work 24 hours every 2 days, it's really a big headache. And also, what I see from the literature, there are a couple of friends, they started very early as cardiologists to do this intervention. We have, for example, this paper, Stefan Rami. He had a paper 2004 saying that the transcatheter intervention can be done by cardiologists in stroke. And also we have another paper from the same group, and also a very good friend of us, Mark Abelson from South Africa, very keen, very good operator, and he published his first paper 2010. And also, as again Asim mentioned, we have very good friend. He's a neurosurgeon, but he helps us a lot regarding acute stroke intervention. Nick Hopkins, he also definitely say that cardiologists should be involved in acute stroke intervention. Otherwise, this therapy will not be therapy for everyone. We have advantages as a cardiologist. We have capable of interventional procedures. We have what's the sheath, what's the wire, what's the stent, and it's quite same logic with the acute coronary syndrome, because it's the time is the brain, time is the muscle. More or less, we have to be hurry. And hemodynamic management, we can handle some problems, and also etiological management for stroke is also related to cardiology. 30% of them has cardioembolic stroke. Of course, we have disadvantages: lack of knowledge for neurovascular anatomy, neurological examination, advanced and basic stroke pathophysiology and complications. but training can solve these problems. Of course, we are aware of the difference. Brain vessels are not coronary vessels. They are so fragile, very thin. We have to be very careful, very gentle. Otherwise, we have problems. And education is important. We have to learn basic neuro, and we have to join multidisciplinary teams. We have to learn neuroanatomy, and we have to learn stroke basics. And also, as a cardiologist, we should learn rapid neuro assessment and imaging. We have to respect the arteries. There are differences I mentioned. I'd like to talk about my team. In our team, we have emergency physician. In our team, we have neurologist, we have stroke physician, interventional neurologist, we have neuroradiologist. He's non-invasive, and we have interventional cardiologist. 3 interventional cardiologists are involved in the team, including myself. In our hospital, we have I'm very proud to say that we have a really good system in our center. We have a stroke cell phone carried by the stroke coordinator. So we have a stroke coordinator, first of all. If there is a patient, she had a cold, and she informed the neurologist saying that there could be a stroke patient. Anyhow, we have protocols for paramedics. We have protocols for emergency department, and also protocol for radiology to have fast CT and MR image. And we have agreement with bed management. We have, of course, work for, we have separate unit for stroke, 7-bed unit. It's not ICU, it's stroke unit, basically. Of course, we have trained nurses in that service. There is a pre-hospital evaluation, of course. If in the paramedic feels that it's stroke, they call us and they inform us. And here, if the patient arrived in the emergency room, they had blood samples and IV catheter right away, and they inform radiology to prepare CT, and also call the stroke neurologist same time. And so we have the information from the stroke coordinator. She's saying that there could be, again, a stroke patient. Then we slow and we look to our cath lab, and we try to organize one of the cath lab ready if we have it. And this should be done in 10 minutes. And the patient goes to CT and had a non-cross CT angio. If the patient is latecomer, we have MR diffusion as well. And TPA starts in the CT lab. Our stroke neurologist is very strict for that. About 25 minutes after patient arrival, decision should be made. And if there is indication for stroke intervention, we have a call, and we saying that the patient is coming to cath lab, and then we have the patient right away. We published our first experience in 2014, and in neuro intervention as a single center. I'm very happy to share with this that because this is our first cases, and we compared this with the results of STAR studies. The results are quite similar. And we are really happy after seeing this, actually. And we had we had a letter between 2 centers with Peter Rimsky, who is very active in Republic of Czech. He's well-known, very well-known cardiologist, and also Mark Abelson and myself. We had a paper as 3 centers, and also we had a letter. So regarding education or training, it's quite difficult to say. It's easy for example, I'm very agree with the Adnan that at least 1 year needed. Yes, true, 1 year needed. But if you talk about very experienced cardiologist, because somebody has to start as a leader. For example, it's quite good example. Asim spent some months, I think 2 months in US, and after he came back to Pakistan, he started the program because he is good, he is very experienced operator. I think if you ask me, and I teach this to my fellows, I saw how quick they learn it. It was quite impressive to me. They really learn it very fast. But they of course used to do carotid stenting in my center. Anyhow, I think any experienced cardiologist, if he spent 1 month any busy stroke intervention cath lab, I think he can start neurointervention, stroke intervention. Otherwise, I think neurointervention should be popular among the young cardiologists, and they should at least spend 1 year in a center. So I think it's good field now for young cardiologists. Many of them go somewhere to do something. I think we have to encourage them to go good places, busy places to learn stroke intervention, and of course basic neurology examination and other things. I think that should be the way. We have to send our fellows to busy centers to get this skill and knowledge and everything. That's my opinion. Of course, there are very good simulators. I believe they are so close to real world. Also, they are very helpful to train someone. That's what I found. So we had 2 certification last year. There is a federation, WIS Federation, World Federation for Interventional Stroke Treatment. This is unique because there are cardiologists in this federation, there are neuroradiologists, there are neurologists, so neurosurgeon as well. This is combined federation. I think we have to be member in this federation to have better and bigger power. And we have a certification that we can do perform acoustic intervention in our unit, and also we can do. They also accept us, the center, under guidance of me as a proctor in my institute. So I'd like to thank them again. So current situation in Turkey, where are we now? We have 28 interventional centers where stroke intervention can be done. And 5 centers run by cardiologists. In my center, we do stroke intervention with interventional neurologists. There is 1 guy, and 3 intervention cardiologists. We are 4 interventionalists in my center. Mostly now, we have, I think, 28, 5 belongs to us, and 8 belongs to neurologists, and the others belongs to neuroradiologists in Turkey. So in conclusion, stroke revascularization is an emergency for sure. Cardiologists have to have the technical skills and right mindset. Infrastructures is already in place, and opening arteries is what interventional cardiologists do every day, so we used to do it. Too many strokes for NIR to handle. Basically, we need manpower here, everywhere, not in Turkey, and everywhere NIR number is so low. And cardiologists on stroke team can remove clot, and neuro experts can manage patients post-op. Thank you very much for your attention.